This is Professor Shafiq Cheema. I'm professor of nephrology and hypertension, and I have been also certified by American Society of Hypertension as a certified hypertension specialist. Currently, I'm working as a professor of nephrology and head of nephrology department at Allama Iqbal Medical College, Jinnah Hospital, Lahore. Today, we will be talking about resistant hypertension or difficult to control hypertension or difficult to control blood pressure. This one is more relevant to the physicians who are currently practicing, the GPs, the nephrologists, the cardiologists, and many other physicians who are in practice and who come across and treat patients with high blood pressure. So we will talk about the definition of resistant hypertension, prevalence of resistant hypertension, what are the possible causes of resistant hypertension, and the main topic is how to approach towards the management of resistant or difficult to control blood pressure. So currently we are following American Heart Association definition of blood pressure, based on which the normal blood pressure is less than 120 by 80. If systolic is between 120 to 129, that is considered elevated blood pressure. If systolic is more than 130 or diastolic is more than 80 but less than 89, that is considered stage 1 hypertension. And if systolic is more than 140 or higher than 90, that is considered stage 2 hypertension. That is equivalent to previous JNC definition of hypertension. Then blood pressure more than 140/90 is hypertension JNC 8. And hypertensive crisis is when blood pressure is higher than 180 systolic and more than 120 diastolic. And if that involves end organ damage like pulmonary edema or brain hemorrhage, that would be hypertensive emergency. So this is a category of blood pressure and definition of blood pressure. But what is resistant hypertension? So the current definition of resistant hypertension is failure to reach a goal blood pressure. If patient is actually taking full dosages or maximally tolerated dosages of an appropriate 3-drug combination that include a diuretic. The things I underline is goal blood pressure, that is based on the guideline and patient's condition, and that keeps on changing. The current is say anything above 130/80 is hypertension. So whatever the goal is, if you are trying to treat that with at least 3 medication and patient is actually taking the medication at maximally tolerated dosages, and specifically the combination has to be appropriate, and that should include a diuretic. You can't be using 2 drugs from the same class and a low dose of diuretic and call it as resistant hypertension, because that would be an inappropriate combination and inappropriate dosages. So it is further categorized into primary drug resistant, like from get-go, blood pressure is difficult to control, or sometime initially blood pressure is well controlled, but with the passage of time, blood pressure suddenly becomes resistant or difficult to control. That would be secondary drug resistance. And then there is a lot of debate on true resistance and pseudo resistance. True resistance would be, we will discuss at the end of this lecture, when you are actually following this definition and have ruled out all other causes and including secondary causes and salt intake and obstructive sleep apnea. At the end of that, if blood pressure is still difficult to control, that would be true resistance. Pseudo resistance would be you are giving 3 drugs, not including diuretic. Are you giving 3 inappropriate drugs or very small dosages? That means apparently it seems like that blood pressure is difficult to control, but that is actually pseudo resistance. You are doing something wrong. So it's an important differentiation. The prevalence varies. Prevalence of resistant hypertension. In 1977, there was a data in which the prevalence was 2.9%. In 82, It was reported to be 13%, then another study 2.9. It also depends if you're talking about true resistance or overall resistant hypertension. There is also a term called refractory hypertension. To me, it is same as resistant hypertension, but if blood pressure is not even controlled with 4 or 5 medications, that is considered by some experts as refractory hypertension. For me, difficult to control blood pressure, resistant hypertension, refractory hypertension, all are same things. So what could be the possible causes? It could be patient resistance, some factors related to the patient causing blood pressure not well controlled. It could be a physician resistance, factors related to doctors, physician. For example, if you're using insufficient dosages, that is not patient's fault. Infrequent administration, irrational combination, inadequate physician education to the patient, and inertia, lack of physician motivation. You don't want to do anything else. Then there would be a drug interactions, office hypertension or white coat hypertension, excessive salt intake, obstructive sleep apnea, and secondary causes of hypertension. Once you have taken care of all of these, then you're actually dealing with the patient with true drug resistant hypertension. So what could be the patient factor? For example, inadequate adherence to the therapeutic regime. For example, in terms of diet, you're giving blood pressure medication, but they keep on taking excessive sodium and salt. They're unable to lose weight. They're consuming alcohol or other product which could increase blood pressure. In terms of medication, they are not taking the medication as prescribed. They are not following the schedule. You have given twice a day drug, they're only taking once or missing the dosages. They're discontinuing the medications, they're not following up appropriately, or they are doing all of the above, but they're using cocaine, alcohol, amphetamine, other drugs of recreation, which could cause the problem and difficult to control blood pressure. What are the clues to the non-compliance? If you have a patient, you have prescribed beta blocker and their resting pulse rate is more than 80, that means they're not taking it. Or even if they're taking it, the dosages is not correct. It's an inappropriate dose, maybe less dose. You have to be able to bring down the pulse rate maybe less than 70 to have an appropriate response. Or a uric acid level that does not increase, or serum potassium level that does not decrease in patient on thiazide diuretic would be a clue. Vagueness about the names, description of tablets, and how often they are taking. For example, they tell you they're taking and you ask them, okay, Diovan, how does it look like? They won't know. They're missing the appointment. They're always complaining about side effects of the medication, the cost of medication. I have had a young patient who stopped taking because of erectile dysfunction. So you need to dig into all of these. Okay, the second factor, physician resistance. Physician resistance could be you're not educating your patients correctly. You need to spend some time. How many times you tell them about the risk of death, stroke, heart attack, heart failure? So if you don't spend enough time explaining, they have to keep on taking this medication forever, and only I could change it. And what could be the complication? They will end up taking it. Many times, inadequate patient education is a big factor. Then inadequate drug regimen. For example, you have given an alpha blocker, a beta blocker, and maybe a calcium channel blocker, but that does not include a diuretic. And inappropriate dosaging. For example, you are giving a beta blocker, say tenormin or a tenolol, but you're giving 25 milligram, it will not work. Inappropriate use or omission of diuretics. You are not giving a diuretic, or you giving a diuretic but at a smaller dose, or a shorter acting diuretic once a day. So this could be summarized into 5 Ds. Either drug regimen is not correct, dosages is not correct, duration is not correct. There is a drug interaction. You have missed a diagnosis, like a secondary diagnosis, like renal artery stenosis, and you're missing a diuretic. So remember 5 Ds. when you are prescribing or dealing with the patient with difficult to control blood pressure. All of this lecture also apply on regular blood pressure when you are choosing a combination and when you need to know what is appropriate and what is not appropriate. So that also is important. So this was a study of 436 patients treated at a hypertension clinic. 21% had resistant hypertension. So they wanted to find out what was the cause. In 83 of 92, they were able to find cause, and in 58 out of 83, they were able to take care of it, treat it. So what did they find? 56%, number one, inadequate medication or not taking diuretic as a number one cause. So whose fault is that? Inadequate medication? Doctors. So this is the biggest physician factor, not using a diuretic or inadequate medication. And then there are other causes, including 10% of office hypertension, secondary hypertension, caffeine, nicotine, alcohol, drug interaction, and all that. But remember, the major factor is inadequate medication. So what could be a rational three-drug combination? You have to use a diuretic, you have to use a sympathetic inhibitor like beta blocker or calcium channel antagonist, and you have to use a vasodilator like hydralazine, minoxidil, AC inhibitor, ARB, or calcium channel inhibitors. But someone might say, okay, they are using a diuretic, a vasodilator, and a sympathetic blocker, but at these dosages. So this would not be a resistant hypertension. This would be an inappropriate drug combination. You are giving an inadequate dose, even though the combination is appropriate, but the dosages is inadequate. So minimally, if you're using your oral diuretic, for example, hydrochlorothiazide, you need to use, at least 50 milligram. Metolazone at least 10 milligram. And if you're using metoprolol, use 200 milligram, or unless the heart rate is less than 60. For atenolol, 100 milligram. For labetalol, maybe up to 600 milligram. Similarly, if you're using losartan, use 100 milligram unless there is a hyperkalemia, rise in creatinine, or some other side effects. Similarly, if you're using amlodipine, 2.5 or 5 milligram will not do anything. Hydralazine, it only comes in 25 milligrams, so you have to use 2 tablets maybe every 6 hours. So this, if with this blood pressure is not controlled, it's an appropriate combination at maximally tolerated dosages, then it would be resistant hypertension. And the reason we have used this combination, because every drug has an action and interaction. So diuretic, by causing negative salt and water balance, will stimulate renin-angiotensin system. So if you use renin-angiotensin system blocker with a diuretic, that will help. Similarly, if you're blocking the sympathetic nervous system, it causes fluid retention. So you add a diuretic. Vasodilator, by decreasing the total peripheral resistance, will increase the cardiac output, fluid retention, stimulation of renin-angiotensin system. So you have to use sympathetic blocker, diuretic, or renin-angiotensin system blockers with that. Then comes, after patient factor, physician factor, the office hypertension or white coat hypertension. It's a pressure response to office visit. Blood pressure is controlled at home, but when you come to doctor's office, blood pressure goes up. Not due to inappropriate cuff size, may lead to overtreatment. This is one of the indications to use ambulatory blood pressure monitoring. It could also rule out mask hypertension, which is a mirror image of office hypertension. The blood pressure is low in the office, high at home. So what are the clues? There is a disparity between home and office blood pressure reading. There is a postural symptom with the treatment, no evidence of target organ damage. And there is a regression of LVH, retinal abnormalities, in the phase of persistently elevated office reading. You have high blood pressure, but no end organ damage. Then comes the drug interaction. Drug interaction could be you're giving appropriate combination, but you're giving them brufen also. You're giving them COX-2 inhibitor, calcineurin inhibitor, contraceptives, cocaine. So you need to look into that. Excessive salt intake, you're doing everything, but they keep on taking the salt. So more sodium intake will not let your blood pressure medication work. So you need to make sure, and the way to check if they are taking higher than recommended, you could do their 24-hour urinary sodium. And if it's more than 90 millimoles per 24 hours, that is significant, that is higher than what they should be taking. And then obstructive sleep apnea has been uh, a significant cause of many patients with resistant hypertension. If you treat it, the blood pressure will go down. Once we have taken care of all of this, then comes secondary causes of hypertension. So many times we don't take into consideration all these factors and we jump to pheochromocytoma, we jump to renal artery stenosis. They are rare. They are not as common. So what are the atypical features which would give you a clue that you are dealing with the secondary hypertension? There are many atypical features, but the most common causes are renal parenchymal disease or chronic kidney disease, renovascular hypertension secondary to renal artery stenosis. Primary hyperaldosteronism is common. More than 10% patients who have resistant hypertension could have primary hyperaldosteronism. Pheochromocytoma is rare. Pseudopheochromocytoma is more common. Hypothyroidism could cause it. There are some other rare secondary causes. So all of these, CKD, renal artery stenosis, renal hyperaldosteronism, we will discuss them independently as one separate lecture, because this is a significant topic and I can't cover it in the overview and how to approach the patient with the resistant hypertension. So once you have taken care of all of these, then you are dealing with a true resistant hypertension, the prevalence of which is probably less than 3 to 5%. And I had made mnemonic for you guys so that you remember. So whenever you're dealing with the resistant hypertension patient, reassess them, take into consideration physician factor, patient factor, and all other things, and make sure you're not missing anything. S for salt intake, sleep apnea, salicylates, and I for inadequate utilization of blood pressure drug, inertia on the part of doctor, and interaction with different drugs. Inertia could be patient come to you taking multiple medication, blood pressure is little bit high, you don't do anything. You're not motivated enough to do anything. As for secondary causes, look for secondary causes. T, make sure many once a day drug, if used twice a day, would work better. For example, amlodipine, losartan, valsartan, telmisartan. And in order to rule out white coat hypertension, do blood pressure monitoring at home, or you could do ambulatory blood pressure monitoring if it's available. And then make sure patients are not non-compliant, because if you have taken care of all of this and patient is not taking the medication, and I have given you the clues, and then you are dealing with the true resistant, and there are different ways to treat with the true resistant hypertension. But one easier way is, once you have difficult to control blood pressure and you have ruled out all these and you are giving 3-drug regimen, you could add a 4th agent. And studies have shown many times if you add medications like spironolactone, aldosterone receptor antagonist, it could significantly increase your chances of taking care of resistant hypertension or controlling the blood pressure. So that would be a 4th line drug. After that come beta blockers and alpha blockers and minoxidil and other medications and direct acting vasodilators. There are different other ways to deal with true resistant hypertension, but that's beyond the scope of this lecture. So with that, I will sign off. Thank you very much. I hope you liked it. And keep on following up and subscribing our channel Good Doctors by Dr. Shafiq Cheema, and you will be getting basically topics, all the lectures on all the different topics which would interest medical students as well as general practitioners and medical officers and house officers. Thank you once again.